pleased to have Dr. Haytham Kaafarani from Harvard Medical School and trauma surgeon from the Brigham, who is here today with us and is going to share his thoughts and share with us his perspective of the surgeon as a second victim. So please welcome to the stage, Haytham.
All right. Good morning, everybody. It's absolute pleasure to be back in person after so many years, and special thanks go to Michael and Patricia and all the staff of the ACS for the invitation. I have no disclosures. I do have some grants related to patient safety and quality, but I have no specific disclosures to this talk except two small ones. The first one, I am at Mass General, and Michael, if you don't know the animosity between Mass General and Brigham, even though it's the same network, you're on for a treat when you go to Boston, not at Brigham. And the second one is, I haven't worn a tie for 6 years. I'm a bow tie guy, but I forgot them in my wife's bag. I just flew from Cape Town and I realized that last night, so I bought this tie from the gift shop. So excuse me if I feel uncomfortable. But I'm talking to you about the surgeon as the second victim. Why am I talking to you about this topic? I mean, surgeons are not known to be touchy-feely. Trauma surgeons are not known to be touchy-feely. Bold, bearded Middle Eastern trauma surgeons are not exactly known for being touchy-feely. I am certainly not known to be touchy-feely in my work. But I do have a small story or short story to share with you. I'm going to take you back about 10 years ago. It was around Christmas 2013. And I was a young trauma surgeon, recently out of fellowship training. And I received a patient back then who was in his late 40s. And he was, and I'm sorry about, this is a room of surgeons, shouldn't be too graphic, but basically it was a factory incident where he was pinned by a forklift against the wall, so crush injury to his pelvis. And then he fell down on the forklift, so was impaled by the forklift. And he came in hemorrhagic shock, pretty much on death doorsteps in the trauma bay. And I took him back then to the OR. It was my calling as a trauma surgeon. We packed his pelvis, fixed the pelvis with the orthopedist, then stopped the bleeding, embolized his internal iliacs. He had an injury to the femoral artery that I actually put a conduit to replace the vascularization to his right leg. I created a colostomy because his rectum was injured. We also put a suprapubic in him and then diverted his urine. He had this big wound in his back. And he was pretty sick for a few days, and I did maybe 6 surgeries on him within the first 72 hours. This was around December 20th or 21st. And I met with his family every day. He had his mother, and he had a 14 and a 16-year-old kids. And every day I would tell them he's not, he's critical, he might not make it, he's critical, he might not make it. But then around December 23rd, 24th, he actually turned the corner. He was in the ICU, he was giving the thumbs up under the sedation, he was doing very well. And I went and sat with his mother and his 2 kids, 14 and 16, to update them. And for the first day, I got a little bit more comfortable. I said, I think he's going to make it. I think we did it. We saved him. I was on my top of my ego as a trauma surgeon. And yeah, things looked good. And then his mother, which is what this picture is, was so excited that this is good news finally, that she made all these Christmas cookies and brought them to me. I shared half of them with the ICU team, and I took half of them to home. And they were in this beautifully decorated box, and I gave it to my daughter, which you can see in the picture. My daughter, she's now 13. She just turned 13 last month. But she loved the box, and she kept it since then in her room. She puts her little letters and notes with her friends in it. But what happened on December 24th, literally Christmas Eve, is I got a phone call from a partner of mine who I will never forget that phone call, because this is what he said. He said, "Dude, your guy is going down the tubes." And some of you who might recognize who would say a sentence like that from my partners, but basically, the guy got really sick, and I went back to the hospital, and what happened is the following. He had developed a really bad necrotizing skin and soft tissue infection in the wound that he had. Now, we had to withdraw care on him on Christmas morning, and he died, and I had to tell his kids and his mother that he died. Now, what bothered me about the case, which is I didn't dare share it with a lot of people for a while, is on the last surgery I did on him, it did cross my mind that the fat did not look shiny. It just looked a bit dull, just had a different color to it than what you expect. And it was the beginning of a necrotizing infection, and I completely missed it. Was I tired? Was I just inexperienced? And I was just remorseful. I felt guilty. And I didn't even dare share that little inner thought in my head for a while. And then only a few years later, I did share it with close friends later on and everything, but only later on I opened up and told the story, because it tormented me for a while, to be honest. And what tormented me more, every time I walked into my daughter's room, that box was there reminding me of the story. So this is when I realized that I actually have a lot more stories. We're going to save you the trouble of them. It was not the only story. It was one that's memorable to me. This is another story where I do some work with Doctors Without Borders, and this was in the Congo, and we totally failed a 13-year-old kid thinking we can save his limb and not amputate above the knee, just treated the infection and ended up needing to do a disarticulation on the hip because of our misjudgment. But it made me realize that out of suffering have emerged the strongest souls. The most massive characters are sealed with scars. And this is a quote by Gibran Khalil Gibran. If you're ever in Boston, in Copley Square, he has actually a big monument there. He's a Lebanese-American author who wrote The Prophet back in the days, for people who have read his book. But actually, me coming to the topic of the second victim, the surgeon as the second victim, came from a totally different angle initially, and only when I put the slides for these talks that I brought that story. It came from a research point of view, and came from this study, the Boston Intraoperative Adverse Events Surgeons Attitude Study. So in my early years of academia, I was focused on patient safety and quality. I was specifically interested in intraoperative quality of care, and when we would do injuries to patients and how to measure the impact on later outcomes, what predictors, how can we prevent, and things like that. So it was kind of my academic focus in the first few years. And one of the students, Harvard medical students who came and worked with me said, you've studied everything, you didn't study how, what surgeons think about it. So we created the study where we distributed the survey across all the Harvard hospitals, so Children's, Brigham, Mass General, and the Beth Israel Hospital. It was an anonymous survey, and one of the items was, how did it impact them emotionally? The other items were about transparency and how they feel. Do they feel comfortable sharing stories about intraoperative adverse events? And that part of the study took a life by itself. So I was surprised to see that 84.1% of respondents, and all surgeons and all specialties, all very experienced with very active practices, 84.1% reported a combination of severe anxiety, guilt, sadness, shame, embarrassment, and anger. And actually quite a few reported they needed formal psychological help after they witnessed intraoperative adverse events or caused intraoperative complications on patients. What was most interesting to me in that study, every study was a Likert, like 1 to 5, agreed, don't agree, but I knew surgeons want to say something. So I just left a little thing in the red cap where they could add anything they want to add if they want to say stuff. And I had pages and pages of these anonymous surgeons' quotes and notes to read through, and they were fascinating. And here's a couple of them. This is one surgeon. I have no idea which hospital. I have no idea who the surgeon is. We all hide our grief, suffer in silence. The pain can be close to debilitating. A lot more quotes. Everyone knows about an intraoperative adverse event within moments. No such thing as a support system, only criticism. The competitive and stay-old culture of surgery at one of those 4 institutions makes it difficult to seek out support openly. The responses at M&M to adverse events is personally critical rather than constructive, even though everyone encounters such events once in a while. Quality and safety system is more focused on blaming surgeons rather than solving safety issues despite their claims otherwise. And a lot more quotes. So this is when I got interested in the second victim syndrome, and I wanted to look into it. And of course, I thought I'm discovering something new. And as soon as you look into literature, you find people have been talking about it for years. This is a quote from Albert Wu, who's actually a good friend at Hopkins. I don't know if Joe knows him there, but he's a good friend. And he wrote this back in the year 2000. He said, virtually every practitioner knows the sickening realization of making a bad mistake. You feel singled out and exposed, seized by the instinct to see if anyone has noticed. You agonize about what to do, whether to tell anyone, what to say. Later, the event replays itself over and over in your mind. You question your competence, but fear to be discovered. You know you should confess, but dread the prospect of potential punishment, of the patient's anger. You may become overly attentive to the patient and family, lamenting the failure to do so earlier. And if you haven't told them, wondering if they know. There's a lot more studies. None of them was about surgeons back then. There was a lot from a nursing literature, but also from the other physician literature. This is another landmark study about it. And red is serious error, and yellow is minor error, and blue is near miss. And you can see there's a huge, the amount of anxiety about future errors was large, decreased job confidence, decreased job satisfaction, increased sleeplessness, and then harm to professional reputation is what people reported, and was the same in many other studies in the literature about the topic. So I know we talk a lot about well-being, and sometimes we reduce it to, you need to do some yoga, and you need to do hula hoops, and but if this is not about surgeon well-being, then what is? And that's the angle I took on it. So the question is, how can we turn this around from being a source of burnout, a source of people quitting, a source of people not feeling well, underperforming, and actually potentially harming patients later on because they're not on their best foot when they're operating. So what can help? And when you look into literature, you figure out that the really one thing that clearly helps is peer support. And there's something to be said about telling someone, I've been in your shoes, I know how it feels, and having the credibility to say so. Having a nephrologist whose mistakes might be related to doing dialysis, not doing dialysis, or choosing which solution to go in the dialysis is very different than having somebody tell you, yeah, I know how it feels when you're like this last snip of the scissors, and that last snip turns a case from being a case with music in the background to blood and packing and calling other people into the OR. So there's something to be said about that. So we did that. We did that at Mass General a few years ago. We created the first surgical peer support systems. And the word surgical is the key component. It's not the first peer support system in the country. There's actually a few across the country, but they're generic. Everybody goes through the same program. So this was a surgery-specific peer support program, and it came with the idea that we can support and collegiality coming from talking to someone who's been there, who can tell you that, has the credibility to say, I've been in your shoes. And we target 3 things to support surgeons: surgical errors, such as intraoperative adverse events, catastrophic outcomes, especially when they are unexpected, and lawsuits. And this is how we created it. There's 5 steps that we created it. I know Marion is here. When she was in Arizona, I actually helped create a similar program in the University of Arizona there, and we've created a few across the country since. But it's the 5 steps are creation of a conceptual framework, the choice of peer supporters, training of the peer supporters, and then how do you identify in a systematic fashion the things that need intervention, and then what is the actual intervention. I don't have time to go into the details, but I'll give you just a quick glimpse of how this works. The conceptual framework is as follows. You will never take away the tier 1, which is the unit that somebody works in, the division they work in. That's kind of the peer support, the support that comes at a baseline for everybody who goes through similar incidents. And the tier 3 is when people need more formal, more professional help, like psychologists or employee assist programs. And what was always missing is the tier 2, which is trained peer supporters. And the way we did it, we made it part of QA, and we made it part of QA in a strategic way. So it belongs now in the umbrella under QA. So it's not, at least theoretically, discoverable by lawyers. So nothing that can be said in these discussions can be discovered by lawyers, and we haven't had any issue with any lawyer asking for any information from the program. But we also made sure the optics are different. It is separate from QA. It's not based on root cause analysis, trying to figure out what happened. The goal is non-judgmental support. And the idea was on the long term, decrease the surgeon burnout and improve patient safety and quality. The choice of peer supporters, like everything, the key to success is to make it sound like an award. So we actually asked the residents, tell us, and the attendings who they go to when they need support and similar, and people, the names floated to the surface, and we send them an email from the chair saying, congratulations, you've been chosen by your peers to be the peer supporter. And then we reserved some time, instead of M&M and grand rounds where we had 3 to 6 hour sessions of training. It was case-based, and again, it's not, I'm not a very fluffy person by nature, but this was actually very, very meaningful session of training where people had to kind of role model and do case-based and watch themselves trying to support their colleagues and realize how much they suck at it, and then have everybody criticize them about it, and then discussions happening around it. It was pretty good. I did recruit experts in the field back then, especially from the anesthesia, who had anesthesia peer support program then, and we also had some really amazing moderators help, and since then we've been doing it ourselves. The systematic identification of events, or anywhere you can identify event, you should count it in. Safety reports, mortality reviews, M&Ms, risk management, division quality directors, but the most important turns out to be the word of mouth. Once the program gets traction, you just get about the same event, 3, 4, 5 emails that come to you, tell you, hey, did you know what happened in OR 55? Can you make sure you reach out to surgeon such and such? He or she might not be doing very well. And this is the word of mouth turned out to be the most important thing. The way it works when such an event comes to my attention, I do send an email that's without too much details about the clinical aspect of things, but I tell them it's an opt-out program, meaning I am sending somebody to them as a peer supporter. They can definitely say no, but the effort is to say no. So it's happening. So I normalize the fact that it's happening. And then we go through the intervention. And again, I don't have too much time to go into details, but this is a flavor of it. There's 6 stages that clinicians commonly experience following an adverse event. First one is what we call the chaos and accident response. Then they have a second one called intrusive reflections, restoring integrity, enduring the inquisition, getting the emotional first aid, and moving on. And hopefully you can increase the number of people going through the thriving and a little bit less surviving, and not as many dropping out from this. So what does it mean? What can the peer supporter do then? And that's what we train them to do. In the chaos and accident response, the important actions for the peer supporter are assessment of the clinician's ability at that moment, on that specific day or that specific week, to be able to continuously and safely take care of their patients, or whether they need some time off. The second stage is the intrusive reflection. It's important to tell them that they expect they will have recurrent thoughts, flashbacks, dreams, that they should practice redirecting their thoughts when this happens, and we kind of have some exercises to teach them how to do that, and then tell them that these intrusive thoughts will decrease in time, and the goal is so that they don't hardwire them into things that develop into maladaptive behaviors in the future. And the most common maladaptive behavior that we see is avoiding the care of similar patients. So if you had similar patient, you start going to IR, you start going to GI intervention, trying just to avoid taking care of a similar patient in the future. The third one is restoring personal identity, and what the peer supporter can really just listen, validate, normalize the peer's feeling. This is where the goal of, I know how it feels, it sucks, it's not going to feel good, but it will pass. That's what's kind of most important for the peer supporter to do. During the acquisition, the peer supporter can remind them that the purpose of the QA process is really not to blame them personally, but to solve systemic issues and improve outcomes. And actually, most people think reflexively that you should avoid, accountability in these issues. That's the worst thing you can do for somebody who knows that they injured or they did some error or a mistake. So actually, M&M is therapeutic to a certain extent, and I don't see the two as mutually exclusive. The more accountability and without too much, if you want, emotional attacks or personal attacks, but accountability is important for them to heal from the process. And if you're wondering, what I found over the last 3 to 4 years is the most difficult part for peer support surgeons to do is really resisting the urge to find solutions, simply listening. We're all wired to jump in to try to help, to find a solution, and that's exactly what you shouldn't be doing. There's no solution for the problem, and just kind of unlearning that tendency to try to resolve and give them solutions or tell them, it's not a big deal. That's just exactly what you shouldn't be doing when you're trying to support your colleague. So how is the program been going? It's live and active, and we have more than 50 interventions per year. And in the first year, I did actually collect some data. We had 47 interventions, and 81% of the surgeons opted in. Only 19% opted out from these, and there were a mix of residents and a mix of surgeons. So both were involved. And we did actually do a little bit of evaluation of the program, and this is published in the paper that if anybody is interested in more details, you can look at it. But I'll save you too much of the details, but to tell you, blue and yellow is good, and the likelihood of recommending the program to colleagues and wanting to become or continue to be peer supporter was all, agree and strongly agree. The program is very well received, and it's now part of the culture. I mean, don't get me wrong, it's MGH. We're still 200 years of tradition unimpeded by medical progress, and we're still harsh on each other. But at least now I kind of see that people in M&M, they still harsh, but they look at me over the shoulders like, make sure you reach out to that person at the end of M&M. So it did have, I think, a positive impact on our safety culture and support. So this is all I have for you, because I'm hoping that some of you will come to the mic and share your own thoughts, your own stories, and maybe some questions. And I do think, I'm hoping with this we can redefine wellness, where it's actually surgeons taking care of each other. All right, thank you.
So we have a couple of microphones set up in the center aisle, and we have some questions that are coming in from the outside. Luke from Member Services would be walking around also if you'd rather have someone bring you a microphone, but we welcome questions from the front line.
Hi, Melanie Edwards from Ypsilanti, Michigan. Congratulations, and this is, well needed and long overdue. I wondered if you looked at the impact of gender. There's some data to suggest that women suffer more reputational harm from these events, and is that something that you have looked at or would investigate in the future? Thank you.
I don't think this is working. Let's see.
It's on.
Yeah, no, thank you. This is a really good question. I have to admit, I haven't thought about it in a scientific way to study it. I mean, one thing I told you, even though we did the study and we published it, and despite making it under QA, I've been really I decided not to keep any notes with any specifics of this program, because I'm always fearful that all it needs is one lawsuit that somehow they get a subpoena and we have to divulge everything that was said, and they call the peer supporter to the court. So I haven't been keeping notes for that fear. So I don't know the answer to you. What I can tell you anecdotally is twofold. One is, I actually think, and that's totally my subjective opinion, that men and women are affected equally by it at a personal level. Whether it affects their personal reputation, I don't know the answer to it. I haven't seen it, to be honest. And if you change the culture of an institution, I haven't seen people's personal reputation being affected as much. It almost normalized, like it's okay to not feel good, and it's okay to reach out for help and take the help when you can. But it's definitely a question worth answering, perhaps with a different scientific methodology, and maybe you're right. I don't know.
Thank you.
Dr. Wood.
Doug Wood from Seattle. I have two questions for you. One is, it seems like intentionally or maybe unintentionally, this is focused on more major events that have a huge impact on an individual. We all know that there are dozens of minor events that occur to us that cumulatively probably have the same effect. And so I'm wondering, whether you've looked at peer support at lower levels of trauma to the surgeons, which connects also to my second question, which is we've developed a similar program, not just in the department, but in our health system. And one of the things we've realized is how little referrals that we get. And so I'm wondering, how did you work to socialize this to really get it accepted and incorporated into the culture? Because I feel like we're still struggling in getting people to think about it and to seek out peer support.
Yeah, no, both fantastic questions, and both actually I have a reasonable answer for them. Let me answer the second question first. So I made this is a key thing. I made it an opt-out program on purpose because I realized early on if I just put a phone there and expect the surgeons are going to call for help, it's just not our macho personality, not our cultural identity where we can do it all and we can just ride through things. So I knew that phone will never ring. So I made an opt-out. So I make the effort that the surgeons need to do is to opt out rather than opt in. Like, it's coming. The peer support is coming to you, and they have to do an effort. No. I really don't need it, and that was the trick. That was my simplistic answer to it. Regarding the lower impact events, I cannot agree with you any more than that. I think there's micro traumas that happen and moral injuries that happen over the years that do affect us, and perhaps on the long term, they're even more harmful than the big events like these. But I had to play a balance between keeping the program meaningful rather than, every patient gets a surgical site infection, like, oh, here you go, like getting an email from Kaafarani again. I don't want that. So the way I do it, I use a lot of judgment in it, and I'm for sure my judgment now is different than 3 years ago when I started the program or 4 years ago. Basically, I put myself in the shoes of whoever was subject to that event. A PGY1 can be affected very differently than a 30-year experienced surgeon, and the events that affect them are very different. So I use a little bit of my judgment of, like, is this an event? I get called about, like, hey, a trauma patient came dead, stayed dead, in the operating room. Does that surgeon who's been doing it for 15 years need peer support? And for a lot of people, the nurses in the room, the anesthesiologist in the room, they might need it. I know that surgeon doesn't need the help, so I actually will not reach out to them. But PGY1 who was trying to do a skin graft and didn't realize there's a big vessel there and went into bleeding, which is a true case, and suddenly started bleeding as he was doing what was supposed to be a low-risk procedure, definitely needs help. So that's how I just use my judgment on who to reach out and when.
Dr. Jarraj.
Rohan Jayaraja, thank you for a great talk. And as somebody that had an adverse event, within relatively recently, and actually was at the scrub sink and actually started to cry because I didn't want to scrub on that next case. This is a really important point. 2 questions for you. One is, for those of us that are not in big academic institutions where this can be operationalized, how would we be able to potentially set this up as more of a remote or mentorship type of program? My second thing is, I would encourage you to think about the other members of the team also, because I can tell you when we have bleeding in the operating room or have an adverse event, my techs are more upset than me even. And so how can we reach out to our ancillary team, which is such an important part of what we do, right? And acknowledging them as also a second victim.
Got you. Do you mind rephrasing the first question? I want to make sure I understand exactly what you're asking.
First question
I got the
is-
second one pretty good.
Yeah, the first question is, in the private world, we don't have as many structural resources as
Right.
possible. In fact, there are many programs that have a quality council, but not necessarily that same cathartic M&M that you're talking about, which actually I think is cathartic.
So the second question first again. The second question is easy. Since we started the program, so the first anesthesia actually had a similar program, and then surgery created a program, and then the institution has realized the importance of such programs that are specialty specific. So we've helped the perioperative nursing create their own peer support program. We've heard OBGYN create their own program, and we're helping other people in the institution create their own program. So when an event happens, it's actually very common that the first notice I get about an event is not coming from a surgeon, but coming from the nursing or the tech world or from the anesthesia world, and the same, and vice versa. So that we do reach out to the team, and we even now created what we call a critical event debriefing program, where if there's an intraoperative death that happens within half an hour of this happening, we all powwow together, and we review what things could have been done, what things went fine, what things didn't go well. But at the end of it, also we identify if somebody specific needs peer support help, and we activate the programs respectively. For your first question, which is in non-academic or private practice or smaller institution, how can we do that? I can tell you that, I wasn't smart enough when I started it. I started on a shoestring. It's just out of sweat and didn't require any major resources or money. So if I did it without the resources, I don't see a real barrier for, non-academic and smaller institutions to do it. All you need somebody who would champion this, who believes. So the first step is to create the need. There's making sure you do enough talking about the topic to make sure this is an issue and we have to address it. And if you do, then you set the stage rightly. But we really do it, everybody volunteers their time. Nobody gets compensated for their time on this.
Dr. Michelazzi.
Fabrizio Michelazzi, New York. Thank you very much. It was a great talk, and you made a very strong argument in favor of having this kind of support systems in every single hospital. We all have seen it. We've gone through it. And from the discussion, I'd like to also thank the college for bringing this topic to our attention. And as you can see from the discussion, it's so good that everybody wants to expand this service to many additional constituencies. And I wonder whether you have thought about expanding it to surgeons who are in the facing or are in the midst of a legal case and a claim. And maybe something bad happened 3 years ago, 4 years ago. Maybe it wasn't even bad. It's just a result of the litigiousness of our society. Nevertheless, those are critical moments for the life of a surgeon. Thank you very much again.
Yeah, no, thank you, Dr. Michelazzi, and for your kind words first. And yes, when I started the program, lawsuits were right there and at the core of what I wanted to reach out for surgeons. I know how it affects them deeply, especially when they put their hard sweat into a specific patient and they get surprised with a lawsuit. And we do reach out, and I have reached out to surgeons with lawsuits, so it is part of what we do. Having said that, I actually think in designing the program, that was the most difficult part to crack at the institution, because I don't know how it is in New York, but in Boston, the first thing when somebody is suing, you get a phone call from risk management. It's like, do not talk to anybody, isolate yourself, turn the shower on. And so you isolate yourself, do not ever talk. So, it's the opposite of what this program is going to do. And I had to actually do a lot of uncomfortable meetings with risk management and lawyers and stuff to try to get them in. And I don't think I reached out as much to surgeons as I'd like to. And the trick is, how do I know that somebody is getting sued is really what I found to be the barrier for this to be as active. If I know somebody is getting sued, I don't care. I'm not known to stay out of trouble too often, but I reached out and I tried. But I know there's a lot of lawsuits that are happening that I'm just not aware of, and the program is not aware of. So that's the real barrier.
We've got time for one more question from the audience, and I think we have maybe a couple of questions online. Dr. Wexner.
Excellent talk, as always. Always learn from you. It's a wonderful program. Congratulations. I'm wondering, what is the mechanism if somebody isn't appropriately responding or responding the way you'd like and recovering and actually going down the rabbit hole the other way? Are there mental health services that can be called in? What is the algorithm? Do you have a different coach for them? Somebody's really getting kind of dark. What resources do you have to call in at that point?
Yeah, no, absolutely. That's a key part of the training, is to at least tackle the subject of what do you do? I mean, none of us are psychologists, so we don't even dream of being psychologists. So what signs should you look for when you're doing your intervention? We call it, walk with coffee. That's what we do it. But how do you recognize that somebody is not doing well? And there are some signs how to recognize that. And the first thing is your intuition, is like that person is not responding emotionally the way you expect them to respond. We have a mechanism of involving the tier 1 of that pyramid, which is the employee assist program. And we have actually a licensed psychiatrist that get involved. And we have referred people, and I have personally referred 2 people to the program because I felt this is beyond what I can do, and I felt they're not doing very well in their mind. They're brewing a lot of thoughts in their mind, like beyond what I can deal with. Then I have done that.
Thanks.
Kathleen, you have a couple of questions for us?
So a couple. So sorry, the microphone's not working. Oh, here we go. So a couple of questions that came in online. How do you address the surgeon who refuses to accept their own culpability for an adverse event? And kind of coupled with that, have you looked at the levels of distress surgeons may feel due to their inability to deliver necessary care due to administrative financial issues of patient safety and access to care?
I'm sorry, do you mind repeating both questions?
Yeah.
Just a bit?
So for the second one, I'll start there. Have you looked at the levels of distress surgeons may feel due to their inability to deliver the necessary care due to administrative financial issues of patient safety and access to care? And then how do you address a surgeon who refuses to accept their own culpability for an adverse event?
Tough one. How do you deal? I mean, this is almost like a topic, but I mean, I actually feel that surgeon is probably the one that needs the most help. If they're just not even acknowledging they're part of the problem, I think they need the most help. They might manifest it later on in very maladaptive ways. So that might be the person I would refer to the EAP and a formal psychiatrist who can make them open up if we're not having them open up. The second one, I have not looked at the distress resulting from, the administrative and financial failure to help the later patient. I have not looked at it. I have not seen it as much. It's a good question, though, so I don't know the answer to it.
All right. Well, thank you very much.